Thank you, Dr. Hassan. So good evening, everyone.
Thank you.
I'm Dr. Rajeshwari, and as you all know, and my topic for today's presentation is differential diagnosis of oral and maxillofacial lesions. I'm going to be presenting it in parts, and so this is the part 1. So let's get started. So before starting, I would like to give a small description about the terms which I'll be liking to use throughout this presentation. So the first term is macule, which is termed as a non-raised area which is altered in color. We can only see it because of the change of the color in the skin. And patch is exactly the similar version, but larger than that of a macule. And this patch I'm going to be using for all the terms of the lesions, which I'll be describing further. Erosion and ulcer, there is a difference because erosion is denudation above the basal layer of epithelium. So this being the basal layer, anything on top of this, if there is lost in continuity, it is called as erosion. And exactly the opposite, if it goes beyond the basal layer of epithelium, it's called as an ulcer. And fissure is a linear crack in the mucosa where it can also enter the connective tissues. And plaque is a flat raised area, which is white, can be any other color. Basically, it's raised and more than 1 centimeter in diameter. Tumor is a deep solid mass, which is 1 centimeter or more, or can be less depending upon the lesion. So I'm going to talk about the mucosal lesions today by the virtue of color change. And as we all know, the most commonest are red and white lesions. And the rest lesions I'm going to be talking in the next part. So white lesions can be further divided into scrapable and the non-scrapable ones. Now, why exactly do we see these different colors of lesions like white and red? Going back to the basics, a quick review. We see a white surface because the visible light is totally reflected. And a black surface absorbs all these wavelengths of light. And that's why there's no reflection, and that's why we see it as black. Red is seen by our eyes as red because the visible light, the wavelength of red is only reflected. What makes these lesions to reflect these particular wavelengths of light? If it's white, then these are the factors, and if it's red, these are the factors. Now, what factors make a lesion reflect white light? For example, hyperkeratosis, meaning there is increase in the production of keratin that causes the reflection of all the wavelength of light, causing in white lesion. Hyperkeratosis, epithelial hyperplasia, necrosis, or pseudomembrane, which can be caused by trauma or fungal. Whereas the red lesion is because of atrophy, meaning the thinning of the epithelium, and also because of increased vascularity. And this reason, it reflects the red wavelength of light, and hence we see it as red lesions. So starting with oral white lesions, it can be classified into numerous ways, but one of the which is I'm going to talk about today is congenital and acquired. And acquired, in which it can be scraped off and it cannot be scraped off. I'm going to discuss our various lesions here. So let's go and start with lesions which can be scraped off. The first one is morsicatio baccarum. So morsus is a Latin word meaning bite. So chronic cheek chafing produces these lesions, and they are found in people who are usually under stress or some psychological conditions. This is almost always bilateral, meaning it's seen on both buccal mucosa. Sometimes it can extend to the labial mucosa. As you see here in this picture, this white wavy line, which is a bit yellowish in tinge, is extending from the posterior region to the anterior region, meaning it's also involving labial mucosa and buccal mucosa. So this lesion, when it occurs on the buccal mucosa, it's called as morsicatio baccarum, and if it is extending to the labial mucosa, it's also called as morsicatio labiorum. This is having a scaly appearance here Otherwise, the patients are all asymptomatic. They usually do not complain of anything and they are not aware sometimes. This is termed under scrapable lesion because these small tissue tags can be separated from the mucosa, and that's why it's termed as a scrapable lesion. Next is thermal burn. The most thermal burn arises from the ingestion of hot food or beverages. Microwave oven has been associated with increased frequency of such thermal injuries because it has the ability to produce food that is cooler on the outside but extremely hot on the inside. For example, this picture shows a case with pizza bun. Here he has or she has burns on the palatal mucosa. It is caused because of the increased temperature. The lesion itself is not white, but it is erythema, which is usually covered by zones of ulcerations, and it has remnants of necrotic epithelium, and that is why it appears as white. And sometimes this can be separated from the underlying mucosa, and that's why it is scrapable. The next example, I'm sorry, is the screen visible? Okay. So the next one is sloughing traumatic lesion. Rubber dam isolation can be reducing iatrogenic mucosal injuries. But when we use cotton roll isolation for moisture control especially, two things happen. The first one, caustic material can leak into the cotton roll and be held against the mucosa. For instance, the cotton roll has been holding against the mucosa for an extended period of time, and this erosion has been caused by chemicals absorbed by the cotton. Second thing, when we rapidly remove that cotton roll, this can cause the stripping of the epithelium, and this denuded area can be covered by epithelial necrosis and underlying erythema of the mucosa involved. Now, how do we treat it? Usually, we have to prevent using cotton rolls which can hold caustic materials. So the first one is prevention. Second one would be resolve. This thing would resolve on itself within 2 weeks. So if the patient is not having any other symptoms, so you can just assure the patient that it is going to heal on itself. Or if the patient is too symptomatic and concerned, we can prescribe the topical biclonium hydrochloride, and it is going to provide excellent pain relief. The same here is a burn caused because of aspirin. The mucosal necrosis seen here is from aspirin, which is being held in the mouth in an attempt to relieve the tooth pain. Aspirin can be obtained in tablet form, it can be obtained in powder form, and that's why these lesions occur, which is less well defined and contains these loosely adherent coagulated white surfaces. And this also can be sometimes separated from the mucosa. That's why it is scrapable one. And what is the treatment of this? Again, reassurance, ask the patient to keep a watch on it, stop using the aspirin and not to keep it in contact with any part of the oral mucosa, and ask the patient to follow up after a week or so. This should be healing. The next one is contact stomatitis. It can be due to allergy. It's a hypersensitivity reaction produced by numerous foods, say food additives, chewing gums, mouthwash, toothpaste for that instance. And these lesions usually disappear when the patient stops using the offending agent. As you see in this picture, the epithelial can be separated from the underlying mucosa. These are all non-keratotic lesions. This forms a thin film-like structure. It can be different. It can simply look erythematous. It can go, if it is chronic, it can form this white filmy structure which can be separated from the underlying mucosa. And what's the treatment of this? You have to first take a very thorough history and ask. The patient will be saying that there is either change in diet or they have changed any mouthwashes or dentifrices. And these can be stopped and kept under observation, and the patients will excellently heal from those lesions. In case they are very symptomatic, we can give them topical anesthetics. The next one is white coated tongue. This condition may perhaps be the result of altered shedding pattern of all the lingual papillae. This is also called as hairy tongue, and it can be white, it can be yellow, it can be green, brown, black. because in this picture it is white, it is called as white coated tongue. And this color is as a result of intrinsic factor. It can be because of chromogenic bacteria, and it can be combined with extrinsic factors like food, like drink, coffee, tea, tobacco, anything which has capability of staining is going to impart that color to the tongue. And what's the treatment? Just advise the patient to keep the hygiene well. Ask him to brush the tongue every day. Ask him to come back in 2 weeks. This would be the result. The next one is an infective etiology. This is called as thrush. This is a pseudomembranous type of candidiasis, and it is the best recognized form of all the candidiasis. As you see in this picture, oral thrush is characterized by adherent, creamy, white plaques. Plaques are slightly elevated. So these you can see as the plaques, which are slightly elevated, and they appear as if it is milk curd, or it's called curdling milk. It's also called as cottage cheese. When you try to separate this cheese-like white structure from the underlying mucosa, it leaves all red base like this. Typically, this red base does not bleed. That's one feature of pseudomembranous candidiasis. Clinical features are more than enough to diagnose these lesions, but if you want to have a definitive diagnosis, then we can do exfoliative cytology, or we can culture them. And the treatment being antifungal drugs, nystatin suspension, though it is too bitter to tolerate, we can still provide nystatin. If not, we can give any imidazole agents like cotrimazole, which is better tolerated. The next one, which is a little rare to see in our day-to-day clinics, but this is a very life-threatening condition which can be produced by Corynebacterium diphtheria. And the symptoms usually starts after 1 to 5 days after exposure. It starts as a very low-grade fever, headache, malaise, anorexia, sore throat, all the symptoms. And for dentists, the main concern where we can look out is, sorry, it produces an oropharyngeal exudate on one of the tonsils or both the tonsils as a patchy yellow-white thin film, and this thickens to form an adherent covering over the tonsils. And the superficial epithelium becomes a part of this exudate. And when we try to remove this epithelium, it starts bleeding. Yes, this epithelium can be separated, but with a little difficulty where the patient will be having bleeding. Since it is infective agent, it can be treated very well with penicillin. The next infective agent which is responsible for forming of scrapable white lesions is secondary syphilis. Syphilis can be, as you know, primary, secondary, tertiary, and many lesions can occur in each stage. The secondary syphilis, can give rise to something called as mucus patches, as you see in these pictures. This is not totally scrapable. It's partially scrapable because it undergoes epithelial necrosis as it ages, and this leads to sloughing of the top layer, and it leaves only raw underlying connective tissue. And this mucus patches can be seen anytime after 4 to 10 weeks of initial infection. And the lesions of secondary syphilis may arise even when the primary syphilis lesions are still present in the oral cavity. Commonly, it occurs on lips, buccal mucosa, tongue, and palate. Sometimes the resolution occurs spontaneously within 3 to 12 weeks. However, they have relapsed. They come with the same lesions next year. So usually treatment is to treat the underlying condition, that is syphilis. And we all know the treatment for syphilis is penicillin. Depending upon the stage, depending upon the condition of the patient, the syphilis is given orally, intramuscularly, and the dose also depends upon the stage. So just to wrap up, all the scrapable lesions, we had first in Morsicaceobacterium, it can occur on the labial mucosa as well. All types of insults like chemical, thermal, iatrogenic, where cotton roll is kept against the mucosa, change in toothpaste, mouthwash, etc. White coated tongue, pseudomembranous candidiasis, and infective lesions. This was a picture of Morsicaceobacterium. It is considered as scrapable because only these tissue tags can be removed. Chemical burn or thermal burn, chemical being aspirin burn, thermal being pizza burn, can be hot beverages, can be anything. It forms an erythematous layer which is covered in it later on by necrotic slough, which can be separated. This is an example to rewind about the cotton roll injury. This is a scrapable epithelium from the underlying mucosa because of change in the toothpaste. This is an example of white coated tongue. This coating, because the patient does not scrape the tongue properly, can be partially scraped off. Classic presentation of pseudomembranous candidiasis, where these cheese-like structures can be scraped off. Next example is diphtheria. It forms as an exudate on one tonsil or both the tonsils, which can become one with the epithelium, and this can be scraped off. Next example was syphilis, called as mucus patches. After a few days, this sloughs away, and this can be removed from the underlying mucosa. These were some of the lesions which could be scraped off. The next one is the lesions, white lesions that cannot be scraped off. Again, the first one will be first developmental. This is called leukoedema. It occurs most commonly in blacks than compared to whites. This relationship supports that it is ethnic in predisposition to development. So this is usually considered as a variation of normal rather than the disease, okay? So clinically, how does it look like? It looks like a gray, white, opalescent pattern of the mucosa, which has a slight wrinkled appearance. And one most important clinical feature of this lesion is when you try to stretch this buccal mucosa or make an attempt to avert this buccal mucosa, this lesion partially disappears. This is the most important clinical features of leukoedema. It's just a variation of normal and not a disease, as I mentioned. So this does not require any treatment. It's usually seen bilaterally in a patient, and it can differ from very thin white layer to a very thick layer, but it can be seen most nicely if it has a dark melanin background. Okay, the next one is linea alba. As we all know, this lesion, it cannot be scraped off, seen almost in people who have persistent rubbing of the buccal mucosa with their teeth. It presents as a wide wavy line of varying length. It is located on buccal mucosa bilaterally. And this lesion are non-tender and smooth on palpation. They can never be scraped off. And it is usually seen in patients who have bruxism or any clenching habit. And how do we treat this? Just treat the underlying cause and these lesions will disappear. The next, this, as we had already discussed under scrapable lesions, this is also classified under non-scrapable lesions because if the patient is not a heavy cheek biting person, these tissue tags will not be formed and then you cannot scrape off this lesion. These were all almost normal variations or due to habitual thickening. And next one is white sponge nevus. This is all hereditary conditions. The next 4 to 5 slides would be all hereditary conditions. And this condition is autosomal dominant hereditary disorder of the mucosa. It is caused by a defect in the process of keratinization. That's why there is increase in the thickness of keratin, giving rise to a white lesion. The patient is totally asymptomatic, and this can be seen manifested already at the birth, or it can be seen during the early development of the child or the early childhood. Now, clinically, as the patient is asymptomatic, they do not come only for these lesions, as I say in the mouth, because it was there since birth. They are seen as thick, white, corrugated or velvety plaques. When I say corrugated, it is like alternate ridges and grooves. You can see nice elevations and then grooves. You can see ridges and grooves. That's how this manifestation is. It is almost seen on all oral sites like buccal mucosa, labial mucosa, tongue, palate, alveolar mucosa, and even the floor of the mouth. Okay, this is primarily a clinical diagnosis. It does not require any other further investigation, just the clinical history, and the diagnosis is straightforward. So no treatment is required for this condition. Next up, another hereditary condition is benign intraepithelial dyskeratosis. This is hereditary, looks exactly similar to white sponge nevus, but here in this case, we have an extra involvement of the eye. Rather than the oral lesions, we have some ocular manifestations as well. When you see this, the white portion of the eye, this is called as bulbar conjunctiva. On this white conjunctiva, you have some plaques which are shiny and seen on the patient's eyes along with these white lesions. Usually when the patient has these white lesions, the patient is always teary-eyed. He has or she has photophobia, and there is always itching of the eyes whenever these gelatinous plaques appear. These are not seen throughout the year. They have a tendency to regress during the summer and become most prominent in the spring season. So whenever they have it as a prominence in spring season, the patient suffers from photophobia, itching of eyes, and there is tearing along with the white lesions, but this does not require any treatment. The next hereditary is Pachyonychia congenita. The patients have white lesions since birth, or they have it during early childhood. Same like white sponge nevus, but here they have extra other features, that is thickening of the nail buds and also on the soles. So it is usually called as palmoplantar hyperkeratosis. You have increased keratin deposition on the palms, on fingers, and also the soles of the feet. And here there's increased keratin production at the base of the nail. That's why they have increased thickening and layering, as if there are top on layers of keratin on top of each other. That's why there is thickening in the nail buds, along with the white lesions of buccal mucosa or the tongue. The diagnosis is again based on history and clinical features, which does not require much of the treatment. But then why do we have to know all these lesions which they do not require treatment? Because next condition, which is dyskeratosis congenita, is exactly similar to all those three lesions described now. But dyskeratosis congenita has a white lesion along with dysplastic changes of the nails. Here, the nail is not getting thickened, but it is changing its appearance. And also, if you notice, the skin has become very thin. So this is hereditary, but it is inherited as recessive autosomal or X-linked trait, meaning male have more predilection to get this disease. And this usually is evident during the first 10 years of life. This causes hyperpigmentation, atrophic skin, meaning thinning of the skin, and there is increased darkening of the skin. And what about intraoral manifestations? It's seen on tongue and buccal mucosa. Usually the patients do not have this white lesion straight away. First, they have blisters, they break down, they cause erosion of the tongue, and eventually they develop these leukoplakic-like lesions, white lesions. If you notice on the tongue here, they are patch-like, and then they become in few areas raised above the surface of them. And this is very important and should not be missed because it can cause atrophy. This atrophy and leukoplakic lesions can further cause malignant changes. And the patient will definitely develop squamous cell carcinoma in a short period of time. Usually 1/3 of them become malignant in a period of 10 to 30 years. So careful inspection of this oral mucosa is very, very important. And it is important to diagnose dyskeratosis congenita and not confuse them with hereditary, other three hereditary non-harmful lesions. Dyskeratosis congenita has got a high chance of malignant transformation into squamous cell carcinoma. So these patients should be under continuous monitoring. The next lesion is the most common lesion called leukoplakia. Now, leuko is white, plakia is patch. So it's simply defined as a white patch. Sometimes it can be seen as a plaque. Plaque is elevated surface, patch is not elevated surface. So it's a white patch or plaque that cannot be characterized clinically or pathologically as any other disease. So this term is strictly clinical term and it cannot be having any specific histopathological alterations. And the cause of this usually remains unknown, but there is a various hypothesis of several factors contributing to these lesions like tobacco, alcohol, UV radiation, microorganisms like HPV, and sometimes trauma. This usually occurs in patients who are middle-aged, say like more than 40 years. And whenever you find these lesions, it is certain that few of these patients will develop squamous cell carcinoma in a period of say 5 years, at least 70% of those. And these people can have leukoplakia on buccal mucosa, gingiva, and lip. The most important sites to be looked for changes are the areas where the mucosa is extremely thin, like lingual, and that is floor of the mouth. These areas to be are observed very frequently and carefully because these are the sites which will show dysplasia or they will turn into carcinoma. How do we see this lesion and how do we differentiate from other lesions? This appears as a white patch which is very well defined from the surrounding mucosa. It does not blend into the surrounding mucosa and it has very clear, distinct margins and has fissures depending upon the stage of the lesion. It can be very thin, called thin leukoplakia. It can be homogeneous and thick, called thick. So there are different stages of leukoplakia, and it can be seen with fissures and very well distinct margins. Whenever we see these lesions, they are to be seen, and a biopsy is mandatory in this lesion. Depending on the biopsy results, we treat these lesions. Say the biopsy shows minimum to no changes or minimum to no dysplasia, then these can be treated by asking the patients to give up the habit and educating them the importance of giving up the habit like smoking and chewing tobacco or tobacco in any form. If there is moderate to severe dysplasia, then entire lesion needs to be removed. Either it can be surgery or laser. In any way, this lesion should be removed in total, or else there is a high chance that it will go and turn into malignant transformation. The next step, which looks similar to leukoplakia, is tobacco pouch keratosis. Basically, this is exclusively caused by tobacco, smokeless tobacco, which can be used in the form of chewing tobacco, moist snuff, or dry snuff. Moist snuff being the most popular, especially in the US region. And this type of lesion can be dependent on various factors like the amount of tobacco, the duration for which it was used, the brand, the frequency, and also the site. Usually the patients who use moist sniff tend to keep the moist sniff very closely in the buccal mucosa or the buccal vestibule, and that is, they favor just one side for some reason. They favor one side, and this site is the buccal vestibule, as you see in the pictures. And when you see, it shows a wrinkled appearance of the mucosa, as if all the mucosa has got wrinkled totally. And this is because of the continuous habit. The patient can be eating this squid for say 16 hours a day, 20 hours a day since 5 years. And this lesion does not develop just within a few days. It takes time. It takes years to develop this lesion. Say approximately at least 5 years is needed to have a pouch keratosis caused by tobacco. And how do we differentiate this lesion? When we try to pull the cheek of the patient to see this lesion, we see when you try to palpate, it is depending upon the stage, it can be white and leathery plaque-like. It's not smooth and velvety. It's very rough and fissured. And when you try to when you try to stretch the mucosa, it reveals a pouch. It is caused because of the flaccidity in the stretched tissues, that it loses all the flexibility. It has become totally flaccid because of the stretching of the tissues, and it's no more firm. and it always appears as rippled. And you can compare it with the sand on the beach after a tide. So when you have a tide washing on the sands of the beach, it shows some wrinkled and fissured appearance. This looks exactly like that. And it's always seen in the vestibules. And what's the treatment of this? Ask the patient to have to do the counseling of the patient to cease his habit. So habit cessation and continuous monitoring. Usually about 98% of these patients heal within 2 weeks after discontinuation of the habit. In case the patient discontinued the habit and it does not heal in, say, for 6 weeks after continuous monitoring, then we have to suspect that it can be a true leukoplakia and we have to biopsy this site. The next lesion caused by tobacco again, especially betel quid. This is an example of betel quid, wherein you have areca nut, slake lime, betel leaf, and sometimes people also add chewing form of tobacco to this, and this is called as quid. People eat this, and it's very, very common in South Asia, and see many patients in South Asian region who have this oral submucous fibrosis. The main complaint of patients with submucous fibrosis is trismus. They cannot open their mouth the way they would open before having a habit of chewing betel quid. This betel quid is chewed, say, for example, 16 to 24 hours a day sometimes, because it has euphorial effect. When you have this areca nut, which combines with slake lime, it releases all alkaloids. And when patient consumes that, they have a feeling of euphoria and they feel everything else is working amazing for them when they eat the squid. And that's how they get addicted, and then they form submucous fibrosis. When you have submucous fibrosis, it's very easy to diagnose because there is distinct blanching of the tissue. As you see here, when you compare this with the uvula, which is not that affected, you can compare the change in the color. This is nice and pink, but this is totally blanched, giving it a marble-like appearance. That's one clinical feature. When you see extraorally, when the patient tries to open his mouth, his interincisal distance is reduced. It can be somewhere around 0 to 20 mm. If it's less than 20 mm, it is considered as a severe. They have different stages. And you can see this pouching in cheek while they try to open their mouth. It feels as if the cheeks have gone down and they have been sucked in. That is a classic appearance, extraoral appearance of the patient who has submucous fibrosis. And when you try to palpate inside the oral cavity, you have horizontal fibrotic bands which transverse the palate at the junction of hard and soft palate. And when the patient attempts to open his mouth, he cannot open his mouth entirely because there is involvement of the pterygomandibular raphe, because of which there is increased fibrosis and there is no more flexibility. Patient can't open his mouth. And how do we treat these cases? If it is mild, the patient will complain of burning even on eating spicy food. We can try to treat the patients with intralesional, meaning the steroids, intralesional corticosteroids are injected in this buccal mucosa or any lesion which is involved along the entire length, or it is given in bits in some spots. And if it's severe cases, then this requires surgery to release the fibers. Next up is lichen planus. It is another white non-scrapable lesion, which is a classic example of immunologically mediated mucocutaneous disorder because it occurs on the skin and also the oral mucosa. It is a classic example of immunologically mediated mucocutaneous disorder. Lichen is nothing but, it's a Latin word for primitive plants which grows on rocks, and planus is flat. So it appears as some primitive plant which grows on plants, which we usually see on rocks. It has got a characteristic feature of very fine white lines which intersect at right angles. For example, this white line intersecting at this white line at right angles. So it forms a lace-like pattern. All these are called as Wickham's striae. This is a characteristic feature of lichen planus. Can be lichen planus is again like they have many types, and this is a classic example of reticular lichen planus where they have Wickham's striae bilaterally on buccal mucus. It can occur on the lips, it can occur on tongue, it can occur on the alveolar ridges, anywhere. So this and another feature to diagnose this lesion is that it can wax and wane. It can completely disappear. It can again reappear within 2 weeks of time. So this is another example where the patient had a reticular lichen planus with some elevations. These are papular type. It has a combination of papule and reticular pattern, that is a combination. And this lesion was flared in a 2 weeks period of time, and this is how it looks. And this is one of the characteristic features. It can increase anytime, and suddenly after 2 weeks it can decrease. Some say that it is hypothesized as depending on the stress levels. So that's lichen planus. Next is hairy leukoplakia. Hairy leukoplakia, as we all know, can be seen in patients who are infected with HIV. So this can be seen as a white lesion caused by Epstein-Barr virus, and it presents as a white asymptomatic. The patient does not have any complaints, no symptoms for these lesions, and it can appear as vertical white patch which cannot be separated from the underlying mucosa. It appears as if it is vertical in appearance, seen as foliate papilla on the lateral border of the tongue. And it is always corrugated. It has elevations and fissures, elevations and fissures. Sometimes it is seen as a flat lesions. And the treatment of this is not required because the patient is already suffering from HIV and is asymptomatic. However, if the patient is concerned about this, acyclovir can be given and treated with success. Next white lesion which cannot be scraped off is a manifestation of renal failure. It is called as uremic stomatitis. This is usually a complication of acute renal failure. This looks more or less like Morsicacio baccharum, or sometimes it looks like hairy leukoplakia on the lateral border of the tongue if it is manifesting. This also looks like red, another white lesions. But how can we differentiate uremic stomatitis from other lesions? The classic feature to distinguish this from others is that when the patient tries to talk to you, you can sense that unpleasant odor of ammonia or a smell like urine from the patient's breath. And the patient also complains like he has unpleasant taste or burning or pain in the oral mucosa, which is not seen in patients with hairy leukoplakia. Next is skin graft. Skin graft can cause white lesions like appearance in the oral mucosa, but a very straightforward diagnosis of history of surgery to treat the underlying cause. For example, leukoplakia, some extensive tumor involving the soft tissue, anything. It can be used as a treatment of any underlying lesion. And the graft can be taken either from the mucosa or the skin and appears as white or yellowish white in appearance. And this is all the skin graft. Straightforward diagnosis of this can be made because of the history of the surgery. And no treatment is required for this. Sometimes if the skin graft is taken, you can have hair growing inside the oral cavity because the graft from the skin. So just to wrap up the non-scrapable lesions, we had normal variations like leukoedema. This, when stretched, disappears partially. Next is linea alba, which can be seen in the occlusal areas where the upper and the lower teeth meet, exactly opposite to the occlusal plane. And the hereditary condition is white spongy nevus, which can be seen right away at the birth or initial days of development. Next is hereditary intraepithelial dyskeratosis, which is benign. White lesions, same like white sponge nevus, but they have extra involvement of eye lesions. This is Pachyonychia congenita, where the patients have white lesions plus thickening of nails and soles of the feet. The important one to remember and differentiate is dyskeratosis congenita, where the patient has white lesions plus atrophic and dystrophic nails, atrophic skin, hyperpigmentation, and this has high propensity for malignant transformation. This is a classic example of leukoplakia where the white lesion is distinctly separate and has a distinct border when compared to the adjacent normal mucosa. And usually it is caused by eliminating all the lesions, which then can only, it's a called clinical term, it's only used for clinic where you cannot have eliminated all other lesions and there is still white lesions remaining. That's called as leukoplakia. This is an example of tobacco pouch keratosis, can be seen as a pouch-like extension with fissured appearance, and patient is known to keep the sniff adjacent to this ridge in the vestibule. Classic example of OSMF, oral submucous fibrosis. Extraoral appearance appears as if the patient has sunken cheek and limited mouth opening with blanching of the mucosa. Next is Wyckham striae lesions, which is lichen planus, appears as if there is lace-like pattern. This is an example of hairy leukoplakia seen in patients with HIV, asymptomatic, no complaints, but can be seen only on the lateral border as vertical striations. This is an example of uremic stomatitis as a complication of acute renal failure. Clinically, you can diagnose this because the patient has bad odor, smells like ammonia, his breath smells like ammonia or that of urine. And this is an example of skin graft or any graft which can be used in the oral mucosa. These are all the examples of white non-scrapable lesions. Next up, we have all red lesions, the first being pharyngitis. Pharyngitis can be caused because of bacterial lesions or it can be caused because of viral reason. When the bacteria is one of the reasons, we can see that it has a white exudate covering the oral, that is tonsillar area or the posterior oral cavity. And in viral pharyngitis, usually we see the red lesions which covers the posterior area of the oral cavity. Patient has again same sudden onset of fever, sore throat, temperature. Here, the patient has very high temperature of say 101 to 104 degree Fahrenheit, and patient has dysphagia and redness of the oropharynx, and they have palatal petechiae. These are pinpoint bleeding spots because the clinical appearance of this bacterial and viral is so much overlapping that it is clinically not really possible to differentiate, but in viral, we don't have these kind of patches and appears only as red. How do we treat these patients? We have to give them antibiotics. Usually they are self-resolving, but we provide them antibiotics just to prevent the occurrence of rheumatic fever and their complications. Next red lesion is because of scarlet fever that is still caused by hemolytic streptococci. In this, they produce toxins, and these toxins can attack the blood vessels, and in scarlet fever, the patients have typical red rash, and that's the clinical hint for diagnosis of scarlet fever. And another clinical features to be checked inside the oral cavity is the presence of strawberry tongue or raspberry tongue. After the infection, say after 2 days of infection, the dorsal surface of the tongue demonstrate white coating and only some pinpoint red dots are seen. And these pinpoint red dots are nothing but your fungiform papillae. And after a few days, this is on the 2nd day, and after the 4th or 5th day, all this epithelial, this white coating is lost. And we see something called as strawberry tongue. This is called as white strawberry tongue when you have this white covering on it. And at the 4th or 5th day of the infection, you have total red tongue. This is called as raspberry tongue. So white strawberry, and then you can call it as red strawberry, or some simply call as raspberry tongue. This is a typical feature of scarlet fever, and the treatment of choice is again penicillin. Okay, we saw pseudomembranous candidiasis, which had white lesions and it can be easily scraped off. We also have another type of candidiasis called as erythematous candidiasis, hence the name, it's always red in appearance. So this is an example of candidiasis when patient was prescribed antibiotics. So that's when they develop the sore tongue, when the patient says, because of antibiotics. That is usually when the immunity also goes down, there is manifestation of candidial infection. And this is a typical example of a steroid inhaler user, chronic user of inhalers containing steroids, which causes local immunosuppression here. And that's why there is superinfection with candidiasis, appears as just red rash on the palate. This is a classic example of erythematous candidiasis, also called multifocal. Here it's called multifocal because it first appears on the tongue, which is called as median rhomboid glossitis. These days they consider median rhomboid glossitis as erythematous candidiasis. And this is seen on the dorsum of the tongue, just anterior to circumvallate papillae. And because of the manifestation of the candida on the dorsum part of the tongue, whenever it touches the palate, it causes another lesion on the palate, candidial infection in the palate. And this is why when you have lesion on the tongue, which touches the palate and causes another infection on the palate, it is called as kissing lesion of oral candidiasis. You here can easily make out that the red patch is in the shape of palatal major connector. And when it is not maintained clean and not maintained well, you can have red patch called as erythematous candidiasis, which is atrophic type. Because the epithelium is thin, it becomes red and it is seen as erythematous candidiasis. This another lesion called angular cheilitis can be seen at the corners of the mouth. It is seen as the red fissured corners of the mouth, and this is infested with candidiasis. The treatment for all of these lesions is antifungal therapy. Give them topical nystatin or topical antifungals. The patient will be fine with few days. And then you have to ask the patient also to maintain their dentures. If it is caused by dentures, ask them to maintain them really well. Next is thermal burn. Thermal burn can also produce red lesions, that is just erosion of the tongue. Next is erythroplakia. WHO defines erythroplakia as a red patch that cannot be clinically or pathologically diagnosed as any other condition. So after eliminating all the lesions which can cause red color of lesion, the diagnosis of erythroplakia is given. It is similar to that of leukoplakia, but it is red. Leukoplakia is white. Erythroplakia is red. This lesion is mostly caused by the chronic use of tobacco. Again, can be seen on floor of the mouth, can be seen on the tongue, it can be seen on palate, it can be seen on buccal mucosa. And the management of this is similar to that of leukoplakia. We have to biopsy, see on which stage the lesion is. If there is mild epithelial dysplasia, then we have to give them topical treatment. For instance, we can give them a form of vitamin A, or it can be combined with beta carotene and it can be treated. But and if you have to delay, you have to see if there are any contributing factors like some sharp crest, some contributing factor like clasp of the dentures, then we have to eliminate that irritating factor, wait for 2 weeks just to do clinical examination. If it is healing, then fine, it was because of the irritating factor. If it's not healing, then consider it as erythroplakia, and depending on the stage and histopathological examination, the treatment can be followed up. Next common manifestation on the tongue is atrophic called red tongue. It's also called as bald tongue because we don't see any papilla on the dorsal surface of the tongue and it is red and shiny. It can involve the entire tongue. It can involve the parts of the tongue like here. This whole area is devoid of any papilla. This area is devoid of any papilla and we have some erosion here. It can be also having some fissures. All these are caused because of anemias. It can be due to iron deficiency. It can be due to vitamin deficiency. So clinically, it is easy to diagnose because the tongue is devoid of any papilla and the blood work of the patient can show some deficiency. Simply treat the anemia and these tongue lesions will be fixed. Next is plasma cell gingivitis. This plasma cell is not a clinical term, but when they saw a histopathology on a histopathological examinations, this type of gingivitis had a numerous count of plasma cells. That's why it's usually a histopathological term, but still used when the patient developed gingivitis as an allergic reaction to any kind of flavoring agent used in chewing gum, toothpaste, food additive, anything. The chief complaint is that the patient has burning sensation in the oral cavity whenever he uses hot food. And it's basically due to any allergen the patient is allergic to. And sometimes it can be used on repeated exposure and not the first exposure of the allergen. This is a classic case where red and swollen gingiva was seen as the patient changed the toothpaste and started using herbal toothpaste for this. So after some mechanical debridement, oral hygiene maintenance, and this is the picture after 4 weeks of periodontal therapy and stoppage of the use of the herbal toothpaste. So allergen is taken off and the lesion starts healing. This can be seen in attached gingiva, pre-marginal gingiva, papillary gingiva, all the areas of gingiva. So hence this is plasma cell gingivitis. Remove the etiology and the patient will be fine. This is a straightforward diagnosis. Patient simply gives a history of radiation therapy for some head and neck, radiotherapy for some head and neck malignancies. And if this is very acute, when the radiotherapy begins within a week or 10 days, patient develops these kind of red lesions, and we have to manage these lesions by giving symptomatic therapy like topical anesthetics, analgesics, and antimicrobial agents. The classic example is topical benzidamine, which helps to relieve the pain. So to just wrap up, the first red lesion was pharyngitis. The next is strawberry tongue, also called as raspberry tongue, seen as a classical picture of scarlet fever. Erythematic candidiasis, this is caused by chronic steroid inhalation caused by denture. And this is an example of thermal burn and lesion of erythroplakia. Erythroplakia also is a very well-defined lesion. It can be distinctly, separated from the surrounding normal mucosa. Okay. Next is anemia, which can be manifested as a bald tongue, bald meaning there's devoid of any papilla. Plasma cell gingivitis, allergic reactions to some allergens manifested on gingiva, and then radiation mucositis as the patient is going radiotherapy. The last section of this presentation is a mixture of red and white lesions. The lesions can appear both red and white, and the typical example of that is erythema migrans, also called as geographic tongue. Everyone knows that this is called as geographic tongue because the lesions keep wandering around and along the entire surface of the tongue. Sometimes it can be seen here, and in next few days it can be seen transferring. The classical presentation of this is again devoid of any papilla on the tongue, and it is usually surrounded by thick white areas. It has nice border, and this border is nothing but desquamated epithelial cells. So they continuously keep changing the pattern. Patient is not symptomatic and he's not worried. Sometimes they have burning sensation and can be managed symptomatically. Next example of red and white lesion is actinic cheilosis. It's also called as actinic cheilitis. In this, the patient has a chronic exposure to sunlight. The patient usually has a history of working in the sunlight for many number of years. It takes at least long-term exposure, say 5 to 6 years of exposure, and usually seen in males than females, approximately in the ratio of 10:1, and appears in adults more than 45 years of age as a result of continuous exposure to the radiation of the sun. The first thing which affects the lips is in a form of blurring of the interface between the lip mucosa and the skin of the mucosa of the lip, sorry. And as the exposure to sunlight increases, they have this crusted ulceration kind of lesions on the lip. And the one typical feature of this crusting ulcer is that the patient mentions that these ulcers and crustaceans can be peeled off. Like, for example, this lesion, which appears on the lip, this can be peeled off by patient themselves and they will reappear again. So this is one classic example. And when you try to check clinically, when you wear the gloves and try to run your index finger across this lip, you feel as if you are running your finger on the sandpaper. That is a clinical example and characteristic feature of actinic cheilosis, sandpaper-like feeling on the tip of your gloved finger. And these lesions, when left untreated, can develop ulcers and cause squamous cell carcinoma. So early diagnosis and biopsy of these lesions are very important to prevent the malignant transformation into squamous cell carcinoma. Now, how do we prevent this from happening? Long exposures of sun can be prevented by wearing good hats or covering the lips or wearing sunscreen before heading out and working in the open sun. Or when it is already manifested, how do we treat it? We can do vermilionectomy, that is surgery, or many alternatives have been proposed, like using laser removal, topical 5-fluorouracil, imiquimod, all immunomodulators, or we can do chemical peel. But this patient needs continuous monitoring, and whenever they develop an ulcer, it's best to biopsy because these lesions can convert into squamous cell carcinoma. And next example of again red and white lesion is lupus erythematosus. It's a classic example of immunologically mediated condition of the vascular or connective tissue disease. The oral lesions are almost seen in presence of skin lesions. Okay, the oral lesions are also present and skin lesions are also present in this kind of patient. How do we differentiate this from other white lesions and red lesions? The oral lesions in lupus erythematosus has these thread-like striae which arise and end abruptly. Whereas in lichen planus, they have lace-like intermingling white striae. But here they are short, straight, and end abruptly and sharply from the surrounding mucosa. And that's why we have the lichen planus as a differential diagnosis of lupus erythematosus, which is really challenging to diagnose. And biopsies can be done, but lichen planus and erythematosus lesions are different in a way in which LE lesions end abruptly in short strokes of striae. Next is nicotine stomatitis. This is also called as smoker's palate. This is caused because the patient keeps smoking tobacco in the form of pipe smoking, cigar smoking, heavy pipe smoking. Any of those reasons can be causing this smoker's palate. It is not caused, this lesion is not caused by tobacco itself, but because of the heat produced while smoking. The elevated temperature rather than the chemicals cause this reaction. here, initially it is covered by a white layer of patch, and we have pinpoint red openings. These are nothing, these pinpoint areas are nothing but the opening of the minor salivary gland ducts. And these can, appear as if they are malignant. These are red and inflamed openings of the ducts, but nothing more. And this is not precancerous. This is not usually going to convert into squamous cell carcinoma. And the treatment is very simple. Simply stop smoking and the lesions start healing. Next is erosive type of lichen planus. We have different kinds of lichen planus: reticular, which has only white keratotic lichen striae. The other type of lichen planus is erosive lichen planus. Here, patient has nice ulcers and it is surrounded by white lace-like striae, which can be seen on the periphery, and the center has ulcer, and that's why it is called erosive type of lichen planus. Sometimes it can be manifested on the gingiva. It appears as if the gingiva is totally red and erythematous, but one clinical point to differentiate it from allergic reactions like plasma cell gingivitis is it is surrounded by white lesions, whereas in plasma cell, which is caused because of allergy, there is no white component. And the treatment for this is topical steroids like clobetasol gel or betamethasone. We can give topical steroids for several times a day, and this lesion usually heals within 2 weeks. Next example of red and white lesion is erythroleukoplakia. It's simply called erythroleukoplakia because it has both red and also white lesion. It has the red and white lesion. This is especially this area in the floor of the mouth. It's to be biopsied whenever we see this because it has a high rate of malignant transformation. Next example of red and white lesion is candidiasis again. As we saw in the first slide also, we have pseudomembranous type of candidiasis wherein the white lesion can be scraped off, leaving a red raw connective tissue. And that's why this is an example of red and white lesion. Just to summarize all red and white lesion, the first one was erythema migrans, also called as geographic tongue. It is always changing its position, so easy to diagnose. Actinic cheilitis, history of long exposure to sunlight. And when you try to run your gloved finger on the labial mucosa or the lower lip, it appears as if you're running your fingers on the sandpaper. Another classic example of lupus erythematosus, wherein there are very sharp, short striae ending abruptly and sharply against the mucosa. These type of lesions usually have skin lesions and other problems as well. Example of smoker's palate, where this is the red color is opening of minor salivary gland ducts. This is an example of erosive lichen planus, erosive because there is an ulcer surrounded by white striae called as Weichen's. Red and white lesions combined, so erythroleukoplakia. Next is candidiasis. White lesion can be scraped off, leaving the red base. Thank you so much for your patient listening. I know it's been a lot of lesions. Thank you.
Thank you very much, Dr. Raj. I have to say that's one of the nicest presentation that I've listened to. It's definitely long, but I wasn't born. I actually listened to it very well. I know that you have put a lot of effort from the way that you presented it. Thank you very much.
Okay, here is the first question. I hope you can see. Can you guys see? Is the first question visible, Fatma?
Yes, it is, doctor. Yes, it is.
Okay. Thank you so much, doctor, for the confirmation. So as I see, most of them have answered the right question. It is nicotine stomatitis because the patient had very significant history of smoking cigarettes. So yes, the first answer is nicotine stomatitis.
Perfect. So we're moving on to question number 2.
Okay. Here's the second question. So that's the right answer. The second question answer is leukoplakia. I'm so amazed everyone is so doing right. Thank you. So there's the next question. Thank you. Okay. So yes, most of them have answered as white spontaneous. That's the right answer. D. The lesion cannot be scraped off, so it cannot be candidiasis, and it cannot be morsicaceous as a diagnosis because the lesion have been there after just few months of birth. So it's a hereditary lesion, so it is white spontaneous. Okay, I'm going for the next question. Yeah. Thank you. So yes, the right answer, as most of them answered, is A. It is bile dung due to anemia. It cannot be erythroplakia because we do not have a demarcating normal mucosa here. The entire tongue is devoid of papilla. And it cannot be strawberry tongue because in strawberry tongue, we still see red papilla, but it is here smooth and shiny. So it is all lost due to anemia. So the right answer is A. So I hope everyone is ready and I can share the answer. As the poll shows, it's C, hairy leukoplakia. A quick thing, it can be confused with leukoplakia, but how to differentiate quickly is the patient is HIV positive. So he is supposed to have hairy leukoplakia rather than plain leukoplakia. Hairy leukoplakia has two. First thing, HIV positive, and it's seen on the lateral border of the tongue. That's the two important features. It cannot be hairy tongue because hairy tongue is mostly seen on the dorsum where the patient does not clean his dorsum of the tongue and the papilla are still there. So it's C, hairy leukoplakia.
Sharing results for question 6.
Okay, the answer for question 6 is A, acute atrophic candidiasis, simply because the patient is asthmatic and he's supposed to be using the asthmatic puff, and that's why candidiasis. Seventh question.
Sharing results for question 7.
So the answer for question 7 is B. It is erythema migrans, and patient is you have to just say the patient that it's going to be fine and it's normal, and if it's only symptomatic, then we can write the treatment. So yes, it's B. That's the next.
Sharing results for question 8.
So here many have answered majority as a D. Okay, the answer for this is C, plasma cell gingivitis, because the patient gives a history that she wanted to have a shiny smile, and that's why she changed her toothpaste. So only after that she developed these lesions. So that's why it is suggestive of an allergy, that's plasma cell gingivitis. It could have been desquamative gingivitis for sure, but patient gives a history of change in toothpaste. So first, the obvious thing first, it can be due to allergy. If the patient does not respond to all these things, then we can think of desquamative. Desquamative gingivitis is not acute, it's a chronic lesion. So looking at the question, giving a history of toothpaste change, it is C.
Sharing results for question 9.
So yes, the answer is D. Last question. All right, so the answer for the last question is actinic cheilitis. The hint for this would be that he is a farmer who is working every day in the open field. So if the lesion is on the lips, working on the open field, it is actinic cheilitis. So that's the last answer. Thank you so much, everyone, for patient listening and bearing with me for such a long presentation. I just request anyone, if you guys have any feedback that it was too lengthy, it was too much in detail, I can cut it short the next time. If you guys have any feedback, please let me know so that it's not going to be so long for the next one. Thank you.
Thank you very much, Dr. Raj. It was even the questions was very, very nice, to be quite honest with you. Guys, do we have any other questions? If not, I think you can always put it on the WhatsApp group. I think it's getting late and a lot of us probably want to go. We want to thank Dr. Raj for such a great presentation. and hopefully we'll see each other on the next time. Stay tuned, for who is going to be the next person to present. Thank you very much, Dr. Raj, again.
Thank you.
Okay,
Have a good
God bless you. Bye-bye. Bye-bye.
night. Bye.